The following podcast is part of a certified educational activity titled Specialty Training for the New Era in Alzheimer's Disease, Building Skills for Making an Early Diagnosis and Implementing Disease-Modifying Treatment. Access the entire activity and complete the post-test at peerview.com/FAP860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Sharon Cohen. I'm a behavioral neurologist and the medical director of the Toronto Memory Program in Toronto, Canada. Welcome to this unique activity exploring the latest evidence supporting new and emerging diagnostic biomarkers and treatments for Alzheimer's disease. Before we begin, let's start with our goals for this activity. Our goals today are 1. To augment awareness of the rationale for identifying patients at risk for Alzheimer's disease early in their disease course. 2. To enhance understanding of the relationship between specific AD biomarkers, the underlying neuropathologic changes that define AD, and the clinical manifestations and severity of cognitive and functional decline. 3. To increase ability to employ validated biomarkers to make an accurate neurobiological diagnosis of Alzheimer's disease in patients who present with cognitive complaints. And 4, to improve ability to apply new and emerging disease-modifying therapies into customized treatment regimens for appropriate patients with biological and clinical characteristics of early AD. Despite Alzheimer's disease being a very common disease, its detection and diagnosis at an early stage in the real world is actually quite poor. The Alzheimer's Association, CMS, and the American Academy of Neurology all recommend early detection and diagnosis of Alzheimer's disease, including at the MCI stage of disease. However, recent estimates show that only 8 to 15% of individuals with MCI actually receive a diagnosis of MCI, and 99% of primary care clinicians underdiagnose MCI. There are validated imaging and fluid biomarkers, but they are not routinely used in the diagnosis of MCI or early AD, despite the fact that published data indicates that biomarkers change the management of patients under investigation for Alzheimer's disease 60% or more of the time. There are multiple barriers that can prevent or delay timely diagnosis of MCI and mild dementia due to Alzheimer's disease, and these include healthcare provider barriers and also patient and community barriers. From the healthcare provider standpoint, many healthcare providers feel their skills are not adequate and they lack confidence to diagnose a serious disease very early. And there's also a sense of disbelief that there's something that the clinician has to offer, and therefore reticence to diagnose a serious disease when they can't do a lot for the individual. Wait lists are also long and growing, so in primary care, it may be frustrating to make a diagnosis and then not be able to have your patient seen by a dementia specialist in a timely manner. And there are other system burdens, including clerical burden, time constraints, lack of reimbursement for complex assessments. From the patient and community perspective, there is a lack of understanding of early Alzheimer's symptoms and a tendency to conflate these with normal aging. And that really works against people coming forward early because they tend to be dismissive of their symptoms. There also may be lack of insight by the individual with memory impairment that there is something significant going on. There may be ethnic and language and cultural barriers to engaging with the healthcare system. And access to healthcare is not uniform across our various countries. So patients may also avoid coming forward with symptoms because of fear of stigma, and fear of being told, they have a very serious disease and nothing can be done for them, or fear of losing their driver's license or becoming a burden to family. So all kinds of realistic fears and stigma that we have to deal with. Despite these barriers, early, timely, accurate diagnosis matters, and there are things we can do when we diagnose people early and accurately. Number one, we are validating a patient's concerns and family's concerns and not being dismissive of the fact that they're noticing some change. We're enabling individuals to make decisions about their health care, what they want for themselves, assigning powers of attorney or updating wills or deciding how they want to live when they are still capable early in the disease and can be active in the decision-making process for themselves. Early diagnosis also allows individuals to make lifestyle changes that can optimize their lives and to access services. And there are a whole host of different support services through advocacy organizations and other organizations that individuals will be able to access once they know their diagnosis. And for the new and emerging disease-modifying treatments, it's particularly important that we don't lose the opportunity to treat early in the disease, because these drugs, at this point, are indicated for individuals with the MCI and mild dementia stage of Alzheimer's disease. So we don't want to ignore symptoms and have a patient drift into moderate stage disease and have lost a treatment opportunity. And even for patients who may not be eligible for the new and emerging disease-modifying therapies, there are many clinical trials that may be relevant for people early in the disease, including prevention trials at the preclinical stage. So how can we improve diagnostic rates, particularly for MCI? Well, we can have a higher level of suspicion. We can screen patients who we may think are at risk. We can increase the use of validated biomarkers and improve the networks of referrals so that in primary care, there is a pathway to refer to a dementia specialist. We need to educate primary care. We need to educate specialists so people take a special interest in early identification. Digital biomarkers may save time if they can assess cognition in a digital manner without the labor-intensive paper and pencil tests or face-to-face kinds of assessments that some of us use. Reliance on multidisciplinary teams can also help to divide up the work stream and improve patient flow and early identification. And ultimately, at the policy level, we need to have policies that allow people to come forward to be taken seriously for their complaints. There needs to be a system that welcomes these patients rather than makes them have to try over and over again to be heard. And better aging in place strategies and strategies to reduce stigma will all work towards this. Biomarkers for Alzheimer's disease really came into focus in 2018 with the ATN criteria, where A stands for amyloid, T for hyperphosphorylated tau, and N for neurodegeneration. And the classification used imaging and CSF biomarkers on a binary positive-negative scale to define whether one was amyloid positive, tau positive, and neurodegeneration positive. And as you see from the table on your right, to have Alzheimer's disease or be on the Alzheimer's continuum, as we called it, one has to be amyloid positive. And then as the disease progresses, we will also become tau positive and neurodegeneration positive. So there's a sequence of events, but it starts with amyloid positivity. And if one is not amyloid positive, no matter how much the clinical phenotype looks like Alzheimer's disease, we do not have a diagnosis of Alzheimer's disease. There's an increasing recognition that different biomarkers in Alzheimer's disease become abnormal at different times. And amyloid becomes abnormal first and up to 20 years before symptoms, tau next and about 5 years before symptoms. Then you get cognitive decline, which drives functional decline, and you go through progressive stages of dementia at that point. Fluid biomarkers in both the amyloid and tau category change earlier than the imaging biomarkers. We now have revised criteria for diagnosis and staging of Alzheimer's disease. And these have some modifications from the 2018 criteria. Now we have core biomarkers, core 1 and core 2 biomarkers, and tau, or T, is divided into T1 and T2, and I'll go through this in a little bit more detail. We also have a category of biomarkers that are non-specific, but are involved in Alzheimer's pathophysiology. And this includes neurodegeneration, as we had in 2018, but also inflammation, which we know is part of the AD pathobiology. As far as biomarkers of non-AD co-pathology, these are common co-pathologies that we see in individuals who have Alzheimer's. So vascular disease, referring to ischemic strokes largely, or α-synuclein pathology, as seen in Lewy body disease or Parkinson's disease. What prompted these revised criteria? Well, biomarkers have continued to evolve. We now have rapid development of plasma biomarkers, and they are reflected in the 2024 criteria, so not just imaging and CSF. We also have disease-modifying drugs on and coming to the market, so there needs to be some way of informing clinical practice with revised criteria. So these shouldn't be just strictly research criteria now. They should at least inform clinical practice. So if we turn to the core 1 biomarkers for AD, these are the biomarkers that change first and indicate amyloid pathology. And diagnosis can be made with any one of the core 1 biomarkers. And interestingly and importantly, the diagnosis with a core 1 biomarker is relevant for people with symptoms, but also for those who are asymptomatic. We have amyloid PET as a gold standard, but we also have T1 biomarkers, phosphorylated and secreted tau, and these change at the same time that amyloid is accumulating in the brain. So these T1 biomarkers and hybrid ratios are felt to reflect the amyloid changes, and that's why they're split from the T2 biomarkers, which you'll see in core 2. Here you see an example of amyloid PET. So amyloid PET was demonstrated to be highly sensitive and specific for amyloid plaque accumulation when validated against neuropathology at autopsy. And the accuracy is around 90% or greater. Plaques begin accumulating 10 to 20 years before clinical symptoms. And amyloid PET provides an early means of diagnosing and lending itself to confirming eligibility for treatment for new disease-modifying treatments. And we know that having biologic confirmation of the diagnosis of Alzheimer's disease, particularly with amyloid PET, was studied in the IDEAS study, and it showed that in MCI and individuals with dementia under investigation for Alzheimer's disease, the management changed 60% or greater of the time. Either patients who were thought to have Alzheimer's actually didn't, and so there was a pursuit of other investigations looking for other causes, or individuals who were not thought to have Alzheimer's disease actually had amyloid positivity and were then appropriately managed and treated for their Alzheimer's disease. Here you see one of 3 FDA-approved CSF assays that would constitute also a core 1 biomarker. So this is A-beta 42/40 ratio, and you can see with the area under the curve that the accuracy, again, is around 90%. And here are the 2 other FDA-approved diagnostic assays for CSF, which are now included as core 1 biomarkers. So p-tau 181 over A-beta 42 and total tau over A beta 42. So you can see, interestingly, the hybrid ratios combine a tau and an amyloid epitope. And again, for these, we have around 90% accuracy. In plasma, we are finding increasing attention on plasma p-tau 217. It seems to perform better than plasma p-tau 181 and p-tau 231, and it also can help predict who's going to progress. So although plasma p-tau 217 doesn't yet have regulatory approval, there's high interest in the ability of this plasma biomarker to improve diagnosis in the future. Let's turn to core 2 biomarkers. And these are the T2 category of biomarkers that are felt to represent AD tau proteinopathy. The core 2 biomarkers consist of tau PET and, in terms of fluid biomarkers, p-tau 205, MTBR 423, and non-phosphorylated tau. And these are largely in CSF, although p-tau 205 is being developed as well in plasma. So of these core 2 biomarkers, only tau PET has regulatory approval in some jurisdictions. The others are still under development, but MTBR 423 has a very high correlation with tau PET signal. So the T2 biomarkers are helpful for staging when combined with a core 1 biomarker. They indicate that there is tau pathology that is closely tied to neurodegeneration and to clinical symptoms. And so when combined with a core 1 biomarker to substantiate the diagnosis of Alzheimer's, then we can stage with a core 2 biomarker and gain information on the likelihood that the symptoms the patient is manifesting are due to Alzheimer's disease rather than to something else. And we can also use T2 biomarkers to inform the risk of progression in people without symptoms. If we look at the biologic staging proposed, it's a scheme of A through D using tau PET, both regional information on tau PET and quantitative information. So if you are stage 1, you have core 1 positivity. But then if you have tau PET signal confined to medial temporal region uptake, then you are at the early biomarker stage B. Once tau starts spreading beyond the medial temporal lobe to the neocortical areas, then depending on whether there's moderate uptake in the neocortex or high neocortical uptake, you will either be at biomarker stage C or D. Positive tau PET also predicts a faster decline than amyloid positivity alone. So while amyloid positivity tells you the person has Alzheimer's disease, in terms of prognosis or rate of decline, we see that tau PET is the modality that gives that information. And that's true whether we're talking about progression from no symptoms or cognitively normal to the mild cognitive impairment stage of Alzheimer's, or from the mild cognitive impairment stage to the dementia stage. Looking now at the other 2 categories of the new criteria for diagnosis and staging, we have biomarkers of nonspecific processes involved in Alzheimer's pathophysiology, and that's the N and the I, N for neurodegeneration and I for inflammation. And we have then a 4th category, biomarkers of non-AD pathology that can be coexisting in someone who has Alzheimer's disease. And this refers to vascular lesions, particularly ischemic strokes, And then α-synuclein, which we can identify with a CSF assay that is important in identifying or ruling out co-pathology of Parkinson's and Lewy body disease. So let's look at this in a little bit more detail here. MRI deserves some discussion. We traditionally have used MRI in the workup of an individual with cognitive impairment who may have MCI or dementia due to Alzheimer's disease, and we've used it generally to rule out non-AD causes of cognitive impairment, such as cerebrovascular disease, mass lesions, including tumors or abscesses, evidence of traumatic brain injury, such as gliosis, subdural hematomas, which may be an alternative explanation for a person's cognitive impairment. But MRI can also help provide supportive evidence for a diagnosis of Alzheimer's disease, and it does this in two ways. There are focal atrophy patterns that are highly suggestive of Alzheimer's disease, and this includes medial temporal lobe or hippocampal atrophy, and microbleeds. Unless there's a history of traumatic brain injury to explain them, microbleeds occur as part of the Alzheimer's amyloid angiopathy, and again, are highly suggestive, although not diagnostic, but highly suggestive of the CAA that accompanies Alzheimer's disease. Thirdly, a baseline MRI is needed to evaluate a patient's eligibility for an amyloid-targeted therapy. And you see in the figure here that there is progressive medial temporal lobe atrophy on MRI from the MCI stage, where we already see hippocampal shrinkage, to the dementia stage, where there's further loss of tissue in the hippocampus. Turning to FDG PET, here we have a nonspecific biomarker of neurodegeneration, and there is a characteristic pattern of hypometabolism on a glucose PET scan in Alzheimer's disease. The typical characteristic pattern that we look for is hypoperfusion in the posterior temporal, posterior parietal regions. And that is distinct from the typical pattern in other neurodegenerative diseases. By way of example, in frontotemporal degeneration, we would expect to see bilateral anterior frontal and anterior temporal hypoperfusion. But it's very important to recognize that these patterns of neurodegeneration, dropout of cells and therefore less glucose uptake, less glucose tracer uptake, are not specific enough to be core 1 biomarkers. So they can inform on neurodegeneration patterns, regional patterns, but one can be misled if one uses them for diagnosis. Another neurodegeneration biomarker of interest is NFL. And this is a biomarker that increases in CSF and plasma in Alzheimer's disease, but it is entirely nonspecific and may actually be more prominently abnormal in other diseases, the frontotemporal degenerations, in head injury, in multiple sclerosis. So while it is a nonspecific biomarker of Alzheimer's disease, it remains to be seen what its utility will be. GFAP, glial fibrillary acidic protein, is a biomarker that we can measure in plasma and in blood, and it's very helpful as an inflammatory biomarker of Alzheimer's disease. It tells us that the microglia and the astrocytes here are particularly active and contributing to the inflammatory processes that lead to some of the neuronal damage in Alzheimer's disease. And we've seen with some of the recent anti-amyloid therapy programs that GFAP responds to therapy, and we see an improvement in GFAP markers with treatment using an amyloid-targeted therapy. Fairly recently, there has been a α-synuclein CSF biomarker. We don't have a PET tracer for alpha-synuclein yet, nor do we have a plasma biomarker, but very exciting that for Parkinson's disease and for Lewy body disease with spinal fluid, we have an assay now, not FDA approved, but I believe breakthrough designation and hopefully soon to be approved to confirm the pathology of Lewy body disease and Parkinson's disease. And why do we take an interest in this in Alzheimer's? Well, it's because there is a very high rate of comorbidity. About 30% of individuals with Alzheimer's disease will also have Lewy body pathology or alpha-synuclein pathology, even if they don't manifest symptoms of Lewy body disease or Parkinson's disease, and whether that will impact their rate of progression of the natural disease of Alzheimer's or the amount of benefit they get from treatment, that remains to be sorted out. But nonetheless, with CSF, we can now measure alpha-synuclein. Appropriate use of AD biomarkers is evolving, and there have been some recent attempts to update previous appropriate use criteria for these biomarkers. And here you see an impressive table that compiles the appropriate use for amyloid PET, for tau PET, as well as for CSF AD biomarkers. And I won't read through this table, consider it a reference for yourselves. But I'll just point out a couple of items here. Individuals who have subjective cognitive decline, so they have cognitive complaints, maybe they feel something's changed in their memory, their objective testing is still normal, they're scoring cognitively unimpaired, but they feel something's wrong, and they have an additional risk factor for Alzheimer's disease, maybe an APOE4 carrier status or a strong family history of Alzheimer's. They are considered appropriate to go ahead with CSF biomarker testing. Other individuals who have more classic age of onset and symptoms of either MCI or Alzheimer's disease are felt to be appropriate to go ahead and be tested with amyloid PET or with tau PET or CSF. So you have choices here, and you certainly don't need to be doing all of these. You choose the one that makes the most sense for your patient and your organization. Individuals who are atypical, perhaps they're quite young or they have atypical phenotypes for Alzheimer's disease, these individuals would be relevant people to have biomarker testing. And then certainly if someone is being considered for an amyloid-targeted therapy, we want to know that there is amyloid confirmation. And so to determine eligibility for treatment for lecanemab, for example, amyloid PET or CSF testing would be appropriate. If we get into future anti-amyloid therapies, it may be that tau PET is important also for eligibility. There are some fairly well agreed upon inappropriate uses of AD biomarkers. We don't want to be testing people or screening cognitively unimpaired people who don't have additional risk factors or concerns unless we're conducting a prevention clinical trial. That would be a special situation, but in clinical practice, we wouldn't be screening at this point cognitively unimpaired individuals with AD biomarkers. Similarly, we would not be using AD biomarkers for any employment purposes, legal purposes, insurance coverage purposes. We would also not be using AD biomarkers instead of genetic testing or in lieu of genetic testing, whether we have someone with autosomal dominant gene mutations for Alzheimer's or APOE4 homozygous status. The biomarkers do not stand in place of genetic testing and vice versa. Each modality of biomarker testing has strengths and limitations, and some of these are more obvious than others. As far as PET amyloid and tau, we have a long history of use and standardization for these ligands. We have FDA approval, and we have very good correlation with pathology. In terms of limitations, access to PET imaging, having enough scanners across the country, cost coverage. These are expensive scans. There's radiation involved. And with each PET scan, you are only going to get the information related to the specific ligand. So if you want to know about amyloid and tau, that's 2 PET scans with twice the cost, twice the radiation. CSF is more widely available. It's more scalable. It's less expensive. The accuracy is well demonstrated for AD biomarkers via CSF. And multiple providers from, neurologists and practitioners in memory clinics or nurse practitioners or others, radiologists can perform the spinal tap. In terms of limitations, there's sometimes a reticence on the part of clinicians and patients to perform an invasive test, although most individuals can tolerate a lumbar puncture. There will be some with contraindications, whether it's spinal deformities or anticoagulant treatments that they cannot stop for the duration of the spinal tap. And there can be some post-LP complications. These are usually not deal breakers, but nonetheless, these are some limitations. As far as the plasma biomarkers, we're very excited. They're developing quickly, and we're waiting for regulatory approval. They hold promise to really provide widespread access, no matter what your geography. It's very easy for most clinicians to order a blood test and to ship a specimen to a lab that can process these special tests. But currently, none of these are reimbursed in the U.S. They don't yet have FDA approval. And what is still required is validation across general populations. So they have been studied in research populations, but how well do they perform in the general population? And this is work that still needs to be done. There can be confounders for AD blood-based biomarkers. There may need to be different cutoffs for normal and abnormal based on age, sex, ethnicity, race. Certain supplements like biotin can influence the plasma biomarker results, and therefore there may be a requirement to hold off on certain supplements before a blood draw. Kidney disease can also alter the readout of plasma biomarkers for AD. And so again, specific cut points need to be established. And then some rarer things, genetic disorders, for example, certain genetic disorders may require different cut points. Here you see a list, really for reference. It's a great list of which biomarkers are FDA approved, which are CLIA certified, and which have breakthrough device designation. And so for the tracers, the amyloid tracers, we have FDA approval for 3 amyloid tracers and 1 tau PET tracer. And we have FDA approval for 3 CSF AD biomarker assays. And as stated earlier, for the blood-based biomarkers, although we're very excited about the rapid development of these biomarkers, we don't have FDA approval for any of them, but we do have CLIA approval for some of them. Let's look at a patient case. Kevin is 56 years old. He presents to primary care with trouble coming up with words. He sometimes substitutes the wrong words and does not complete his sentences. He also notes that his spelling has declined. He endorses, when asked, mild change in memory and mild difficulty multitasking, but speaking is his main concern. And he's withdrawn from social interactions due to his trouble communicating, and he's mildly anxious and has mild depressive symptoms due to his difficulties communicating. As far as past medical history, he was diagnosed with hypertension 7 years ago and is being treated for this. He had a concussion in a motor vehicle accident 5 years ago, but made a full recovery. He's on lisinopril for hypertension. He exercises regularly and eats a healthy diet. He drinks on average 6 alcoholic beverages per week. And his routine blood work is normal, including TSH and B12. His family history is negative for dementia. His mother is living and cognitively well, and his father died of a stroke at 72. Kevin underwent neuropsychological assessment, both cognitive and functional assessment, and assessment of mood. His MMSE is near normal, 25 out of 30, but global CDR score of 0.5 with the sum of boxes score of 2.5. And to break down different domains and other tests, there is impairment in working memory, also phonemic fluency, semantic fluency. His picture naming test showed anomia with a score of 10 out of 15, and some impairment on verbal memory for encoding and retrieval, and also visual spatial impairment, which didn't come through in his symptom history. He has mild depressive symptoms, and on the functional activity questionnaire, he has some difficulty with doing taxes, but he still does them independently. He still plays games of skill and strategy, so he's independent in his daily activities. He's still working as well. So given that there's objective evidence of cognitive impairment, but he's still functionally independent, his clinical diagnosis is mild cognitive impairment. But what is the underlying cause? This is where we really need to be rigorous in saying, okay, syndrome is MCI. What's the underlying cause? We need to take it to the next step. And he's young, is he too young for AD? Doesn't have a family history, and we don't know his APOE genotype. And his complaints are mainly in the language domain. So could he have FTD? That would certainly be in the differential diagnosis. So in terms of further investigations, a structural MRI, a structural brain scan in form of an MRI was performed, and this shows mild microangiopathy. So it doesn't really help us either way in terms of the underlying differential diagnosis that we've put forward. So what do we do next? Well, he had biomarker testing. He had a lumbar puncture with CSF that showed us that his p-tau 181 over A beta 42 is elevated. So this is an abnormal COR1 biomarker, and despite his young age and his language-dominant symptoms, he has Alzheimer's disease according to this COR1 biomarker. A tau PET scan was then ordered to further stage his disease, and this showed moderate uptake in the neocortex, both in the left frontal and bitemporal neocortical regions. So as far as biologic staging, using this A through D staging, he's a stage C with tau PET moderate neocortical uptake. What about clinical staging? This works a little bit differently. So the updated or revised criteria for diagnosis and staging of Alzheimer's disease in 2024 have retained the 1 to 6 clinical staging from the 2018 criteria, and they've added stage 0 to represent individuals who are born with either deterministic gene mutations or trisomy 21 and will develop Alzheimer's, but at this time they are asymptomatic and have no COR1 biomarker showing that they have Alzheimer's disease yet. So that's stage 0. The other stages, stage 1 and 2, are this preclinical AD stage, either asymptomatic in stage 1 or subtle symptoms still cognitively normal in stage 2. Stage 3 is equivalent to MCI, and stage 4, 5, and 6 represent mild, moderate, and severe dementia with increasing levels of functional impairment. Importantly, the amyloid-targeted therapies, as mentioned earlier, are approved for the MCI, stage 3, or the mild dementia stage, stage 4 of Alzheimer's disease. If we try to integrate biological and clinical staging, we have this interesting representation from the 2024 criteria. And what we see is, in the gray boxes, a progression that seems logical, A1, 2B, 3C, 4D, which would be sort of the perfect progression if biological staging and clinical staging were in lockstep. But we know that clinical presentations reflect both resilience and cognitive reserve, and so people may progress less quickly than their biology might predict. And we see this in the green boxes or below the gray diagonal line. And those people who may have comorbidities or less resilience in the brain for whatever reasons may progress more quickly clinically. And we see this represented in the blue boxes above the gray line. We are now in the era of anti-amyloid monoclonal antibody therapies. This began in June 2021, with aducanumab being the first drug approved by the FDA as a disease-modifying treatment for Alzheimer's. And it was indicated for early AD. It received accelerated approval based on amyloid lowering with a conditional confirmatory trial required to receive full approval. Then in January 2023, a second monoclonal antibody targeting amyloid, lecanemab, received accelerated pathway approval based on phase 2 data. And by July 2023, lecanemab received full traditional FDA approval for the treatment of early AD based on its Clarity AD phase 3 results. In January of this year, 2024, the manufacturer of aducanumab announced discontinuation of aducanumab, so that will no longer be a treatment option for individuals. However, donanemab is under review by the FDA, and we are expecting in the 2024 that there will be an AdCom advisory board and a decision made about approval of donanemab. If we look at the lecanemab phase 3 results, what we see here is that on the primary CDR sum of boxes and the key secondary clinical endpoints, lecanemab slowed progression of disease across all of these endpoints. And for the CDR sum of boxes, the primary, there was 27% slowing of disease over the 18 months of the trial. Similarly, if you look at the panel below with the ADCS-MCI-ADL, a functional scale, we see that in patients with early Alzheimer's disease, there was 37% slowing of functional decline by 18 months. Importantly, you see a separation between placebo-treated and active-treated patients as early as 6 months, and a separation that grows over the 18-month duration of the trial, meaning the longer people are treated, the greater the benefit. Lecanemab targets aggregated amyloid and has a special affinity for protofibrils, and here you see on your left, as early as 3 months, very robust lowering of amyloid. By 18 months, we've continued to have a progressive lowering and clearing of amyloid from the brain, such that the majority of patients at 18 months are amyloid negative on PET imaging. We see also for amyloid markers in the CSF and plasma, the normalization of A beta 42 over 40 in both these fluid modalities. And if we look at downstream markers, even though lecanemab targets amyloid, we see improvement in tau and neurodegeneration biomarkers, with CSF phospho-tau 181 and plasma p-tau 181 improving, and the markers of inflammation, GFAP, and neurogranin, which is a synaptic marker, also improving over the course of the disease for the treated patients. If we turn to donanemab, this antibody also met its primary and secondary clinical endpoints, and it targets more specifically plaque-bound amyloid, whereas lecanemab has a predilection for protofibrillar amyloid. So with the donanemab phase 3 program, the main population of interest were individuals who entered the trial with early AD and had low to medium tau in the brain, but the total population included those studied in the trial who also had high tau levels. And you can see that the lower tau group obtained 35% slowing on the primary outcome measure at 76 weeks, whereas the combined population had more like 22% slowing by donanemab at 76 weeks. If we look at the CDR in the low tau group, so CDR now, not the iADRS, so CDR was a secondary outcome measure, we see 36% slowing by donanemab, and in the combined population studied in the trial, 29% slowing at 76 weeks. We also see very robust impact on amyloid lowering and clearance of amyloid in the majority of patients by the 76-week duration of the trial. And similarly, we see improvement in tau biomarkers, and in this case, it's plasma p-tau 217 that is the tau epitope being measured. So when it comes to selecting the right patients to treat with an anti-amyloid antibody, we want to make sure that we're following the FDA prescribing information, and we may want to supplement the appropriate use recommendations. These have been published for lecanemab and are available for those who are interested in reviewing them. So I think it's relevant to note that the appropriate use recommendations for lecanemab are a little more restrictive than the FDA prescribing information. We need to have patients who have MCI or mild dementia by clinical diagnosis, and then they need to have confirmed amyloid positivity by PET or CSF. They need a cognitive test to establish that they are in the MCI or mild AD range, and this can be operationalized as an MMSE of 22 to 30 or an equivalent score on a comparable test, maybe a MoCA of 18 out of 30 or greater. Individuals also need to be able to undergo an MRI because CAT scan is not going to be satisfactory to detect any exclusionary factors or to monitor for ARIA. So only individuals who can have MRIs, perhaps not those with pacemakers, will have to be excluded if they can't undergo the MRI procedure. Now, the pretreatment MRI also has to meet certain criteria. It can't show an excessive number of microbleeds. It can't have excessive white matter disease. So there are a number of factors here, and these are for safety reasons because we feel that individuals will be at higher risk of ARIA if they have an undue burden of CAA or they've had lacunar infarcts in the past. Anticoagulation use is an exclusionary criteria according to the appropriate use restrictions, and individuals need to be medically stable. APOE genotyping is recommended both by the FDA and the appropriate use recommendation guidelines because it helps inform risk-benefit discussions between clinicians and patients. We know that APOE4 carrier status predicts a higher risk of ARIA. So in terms of a step-by-step guidance of how to work up a patient, we need to confirm by history and cognitive assessment that we have a patient with MCI or mild dementia presumed to be on the basis of Alzheimer's disease, then proceed to structural imaging to rule out non-AD pathologies, and this structural brain image could also be the pre-treatment baseline if one is contemplating anti-amyloid therapy. But you need to make sure that the appropriate sequences on MRI are performed so that we can evaluate whether there's evidence of microbleeds or possibly of vasogenic edema or other exclusionary features. So if MRI seems to line up and not show any exclusionary factors for an amyloid-targeted therapy, then we would confirm the biologic diagnosis of Alzheimer's disease using a COR1 biomarker. If an MRI hasn't already been performed, that would be the next step, and we would also consider APOE genotyping to aid ourselves and the patient in a discussion regarding risk-benefit. Step 5 would be to go ahead and initiate the anti-amyloid therapy, making sure that we've educated patients and family members about the potential benefits and risks, and of the risks, infusion-related reaction and ARIA and actions to mitigate these risks need to be discussed carefully. And finally, there will be a pre-scheduled set of MRIs that will be needed to monitor for ARIA, and one must also be prepared to have unscheduled MRIs should symptoms of ARIA arise at times that are not corresponding with the pre-scheduled MRIs. There's some practical tips that are helpful for those starting up in clinical practice using anti-amyloid monoclonal antibodies. Site-specific protocols can be helpful and take into account the roles and communication strategies between all stakeholders. If one is not infusing patients in one's own clinic, one should visit the external infusion center, make sure they understand how you like things done and how you want your patients handled and how you want to be notified about infusion reactions or other untoward events. It's good to, in some cases, have a consensus process if there are patients who may be borderline in terms of their eligibility, or if you have staff who are particularly skilled with anti-amyloid therapies and other staff who are just beginning to become familiar, some kind of consensus panel to discuss eligibility may be helpful. You want to make sure that you have the local radiology and nuclear medicine capacity and support for the scans that you need and the expertise in reading them and communicating results in a timely manner. Meeting with the emergency room department or communicating with them is very important because we have seen that individuals who develop symptoms of ARIA may have focal symptoms that mimic stroke, an ischemic stroke. And we want to be very sure that these individuals have the benefit of proper differential diagnosis and not a knee-jerk reaction to receive TPA, for example, based on an assumption they're having an ischemic stroke when perhaps they're experiencing symptoms of ARIA. Any physicians covering for one's practice need to be aware of ARIA and its management, and it may be very helpful for patients to either have a wallet card or a medical alert bracelet that lets other providers, including emergency room providers, know that they are on an amyloid monoclonal antibody. Let's talk about amyloid-related imaging abnormalities. I mentioned infusion-related reactions are a possible adverse event from the class of drug, anti-amyloid monoclonal antibodies, but they are usually more familiar to providers and fairly readily managed. ARIA is new for many healthcare providers. ARIA results from amyloid in cerebral blood vessels, and these blood vessels become leaky, and ARIA can occur spontaneously without anti-amyloid treatment. However, the rate of ARIA increases in those receiving amyloid-targeted therapy. There are two types of ARIA: ARIA-E, brain swelling, also called vasogenic edema, and ARIA-H. And this can take the form of microhemorrhage, that's the most common, superficial siderosis, and rarely macrohemorrhage. ARIA is typically a radiologic phenomenon and asymptomatic, and it resolves over time spontaneously. When symptoms occur, they are usually mild or moderate. They can present as headache or dizziness, for example. However, rarely serious and life-threatening events can occur, such as seizure, and we need to be mindful of this. In the lower panel of this slide, you see 4 examples of ARIA-E, vasogenic edema. And you see that it can be multifocal, it can be very small in size or large diameter, and different regions of the brain can be affected. With ARIA-H, these little holes in the brain are the microbleeds. And again, you need the right sequences on MRI to see them. And what we would like is our radiologist to actually count them and report to us where they are and how many. Risk factors for ARIA include ApoE4 carrier status, and one copy of ApoE4 is not as high a risk as 2 copies of ApoE4. So the risk goes substantially up when you're an ApoE4 homozygote. The dose of the anti-amyloid monoclonal antibody also impacts the risk of ARIA. The presence and severity of underlying cerebral amyloid angiopathy affects the risk of ARIA, and the presence of extensive ischemic cerebrovascular white matter disease also raises the risk of ARIA. Anti-amyloid monoclonal therapies require MRI assessment and monitoring, and so you need an MRI at least within 1 year prior to initiating therapy, and you need to schedule MRIs for monitoring for ARIA. In the case of lecanemab, 3 MRIs within the first several months of treatment. You also need to be ready to order an unscheduled MRI should someone develop symptoms that sound like ARIA, an unsuspected headache in a person who doesn't usually have headache, or some new dizziness or visual change, and ensure that you get an unscheduled MRI to rule out ARIA as the cause of those symptoms. Some of the symptoms or findings that should trigger an unscheduled MRI for patients on anti-amyloid therapy would include focal and non-focal, acute or subacute symptoms and signs. So headache, as I've mentioned, confusion or altered mental state, dizziness, vertigo, nausea, vomiting, fatigue, visual disturbance, gait disturbance, and seizures. And clinical symptoms suspected to be related to ARIA should be classified as mild, moderate, or severe symptoms. When it comes to classifying ARIA radiographically in terms of severity, this depends on, number one, the type of ARIA, whether it's ARIA-E or ARIA-H, the location and the size of the lesions and the number of the lesions. So for ARIA-E, if there's one location of ARIA-E and it's less than 5 centimeters in diameter, that's mild ARIA-E. If it's greater than 5, up to 10 centimeters, or there's more than one location of ARIA-E in the brain, that puts us in the moderate category. And if we have an area of ARIA-E that's larger than 10 centimeters or multiple areas of large size ARIA-E, we're in the severe category. As far as microhemorrhages, we call less than 4 new microhemorrhages mild ARIA-H. If we develop 5 to 9 new microhemorrhages after starting an amyloid targeting therapy, that's moderate radiographic severity, and more than 10 would be considered severe. And so you see why it's important that the radiologist not just say there's a few scattered microhemorrhages. We need to know how many. For superficial siderosis, the mild, moderate, severe rating is fairly simple and straightforward. 1 focal area, 2 focal areas of superficial siderosis, or more than 2 putting you in the severe category. So how do we manage ARIA? We understand that we need to know whether there are symptoms or not. We need to know the severity of the ARIA radiographically. So if someone has mild radiographic ARIA, but they are asymptomatic, we can continue dosing. If they are symptomatic, we hold the dose until symptoms stabilize or resolve and ARIA resolves. If we have moderate to severe radiographic ARIA-E or ARIA-H of moderate severity, dosing is suspended even if the patient is asymptomatic. And we would suspend the dosing until resolution of ARIA-E or stabilization of ARIA-H. For severe ARIA-H or brain hemorrhage, macrohemorrhage greater than 1 centimeter, dosing would be permanently discontinued. So very importantly, we want to educate patients families, care partners about ARIA so that they can be prepared to partner with us and deal with this in an expeditious manner. We want to explain what ARIA is. We don't want to frighten people. It is a common event with anti-amyloid therapies, but generally asymptomatic and resolves spontaneously. And we can monitor for it, we can detect it on MRI, and we can manage it. It presents, as we've said, two types. I usually tell my patients brain swelling or small spots of bleeding on an MRI that may have no symptoms. And knowing one's APOE genotype will help us know what the risk of ARIA is for any given individual, if an individual consents to APOE genotyping. And I do let patients know that even though ARIA is generally asymptomatic, to be on the lookout for a new headache, new sense of confusion or dizziness, nausea, gait disturbance, visual disturbance, or anything even more dramatic like a seizure, and to be in touch with us or go to the emergency room. We like our patients to know how to reach us on an urgent basis so we can either see them and evaluate them in the clinic and order an unscheduled MRI, or if it's a very serious symptom they've developed and they go to the emergency room, we also want to make sure that they let the emergency doc know to contact us so we can discuss the fact that the patient's on anti-amyloid therapy and maybe having an ARIA event. So that concludes our question-based assessment on the timely diagnosis and management of early AD. Please review your learning plan summary before you leave, and I hope you found this activity informative and useful for your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FAP860. This activity is supported by an educational grant from Lilly.